So, thank you again, everyone, for joining our webinar on writing resilient healthcare into policy. So, research has obviously demonstrated the important role that policy plays in facilitating or impeding work performance within healthcare organisations. And this is particularly evident at the moment when we've got healthcare systems that are experiencing demand pressures, workforce shortages, and increased standardisation. So we've got two brilliant speakers joining us today, Carl Horsley and Jan-Willem Weenink, and they're going to talk to us today about the role that policy plays in resilient performance and how they've been their experiences of writing resilient healthcare into policy. So, as an introduction to our speakers, Dr. Carl Horsley is an intensivist working in Middlemore Hospital in Auckland, New Zealand. Many of you will know him. He's got a background in emergency medicine, and within his role, he's focused on the practical application of resilience engineering within healthcare and use of simulation to build resilient teams and to test systems. So Carl's completed an MSc in Human Factors and System Safety at Lund University, with his thesis focusing on the sociology of safety. And alongside this, as if he wasn't busy enough, Carl works for the Health Quality and Safety Commission in New Zealand as clinical lead for system safety, where he's helping to embed system safety approaches and resilient healthcare into the way they design, learn about their systems and support good care at all levels. And Carl has also just been recently appointed to the Resilient Healthcare Society Executive Committee, and congratulations. Next up, we have Associate Professor Jan-Willem Weenink. He's a health services researcher with over 10 years' experience in the Dutch and Australian healthcare systems. His research focuses on quality and safety of healthcare, regulation of healthcare professionals and performance measurement and reporting. And he currently works as Associate Professor at Erasmus University in Rotterdam, leading research projects on healthcare regulation. He is Programme Director of the Healthcare Management Masters. Jan-Willem completed a bachelor's degree in biomedical sciences, a master's degree in health technology assessment, and a PhD in medical sciences. So previously, he's held positions at IQ Healthcare in Radboud University Medical Centre in Nijmegen in the Netherlands, and at the Bureau of Health Information in the Centre for Primary Healthcare and Equity at the University of New South Wales in Australia. So for those who don't know me, it's lovely to see some familiar faces, but some also new ones. I'm Ruth Baxter. I'm a research fellow at the University of Leeds in the UK, and I'm currently partway through a postdoc fellowship, which is exploring how principles of resilient healthcare can be used to support safety improvement. So Carl and Jan-Willem are going to present for approximately 7 minutes or so, basically with the premise that we want to leave a really good amount of time at the end to have a great discussion between us all. We've promised that it won't be a kind of grilling of question and answers for Carl and Jan-Willem, so yeah, please do put your hand up using the emoji function or use the chat, and we'll invite comment and discussion after the presentations. But really, without further ado, I'm going to would like to welcome Jan-Willem firstly to present. Off you go.
Yes, thank you so much, Ruth. And let me share my screen. I think this should be on full text now. Can you not, Ruth? Yeah, okay, that's great. Yeah, you asked me to do it in 7 minutes, and I didn't know I was getting such a great introduction from you. So I had a slide on my introduction, but I can skip that. So I've got maybe some extra time to talk now about the content that I want to talk about. But maybe a bit as a recap. So my focus is on quality and safety. What might be interesting is how I approach this topic is that we often in our research focus on the interaction between what we call the micro, meso, and macro levels. So what's happening on an individual level and on a team's level, what's happening on an organizational level, and what's happening on a national level. And that both relates to the policies, but also to the practices on these levels. And I think you already mentioned that I've got quite some experience in healthcare regulation as well. We do a lot of work with regulators, both nationally and internationally. And I do some teaching around healthcare management. And so following that expertise, I thought I want to raise a couple of things, maybe also for this discussion later on, and want to focus on three aspects on what you asked us to talk about, namely how do you write healthcare or resilient healthcare in policy in those different levels. And I want to focus on regulation, on organizational policy, and on education. And I think the question that was put to Carl and me was also like, why should we do that? So why should we focus on these levels? And how can we then do that? And I want to share some insights from both the research that we've been doing in the past years, but also what we see happening on these levels in practice. And I think Carl later on will share a bit on the New Zealand perspective on how to write resilient healthcare into policy. So to start off with regulation, as I said, we've been doing research into regulation and with regulators for quite a time now. And what we see, and you might recognize this as well when you work in practice as a healthcare professional or a manager or maybe in another function, is that what is being regulated and how this is being done steers the policy and practices within healthcare providers and ultimately the behavior of individual healthcare professionals. Now, this can be a positive thing. Often, I think when you ask healthcare professionals, they experience this as a negative thing. But just to give an example, what we've seen in practice, we've done a study a couple of years ago on how the inspection frameworks that the Dutch healthcare regulator uses and how that they publish, how that might impact the work that's being done within healthcare providers. So the Dutch healthcare regulator, they publish their inspection frameworks consisting of the norms and the standards that they assess, but also how they assess it. For example, if it's a tick box, if you get a color code, if it's an open norm where you just have to explain how you do certain things. And we see that that impacts on how healthcare providers work on quality improvement within their organization. So you see that, for example, it steers on what is being focused on. And what happens in practice is, for example, healthcare providers, and most often the healthcare quality officers within those providers, put the themes that are in those inspection frameworks on the agenda, and they put resources towards it. And this can be a very positive thing if you want these healthcare providers to address these themes, but it does mean that what you put in those inspection frameworks and how you put it in, that matters. And I think if you look at least in the Dutch healthcare sector, say at regulation 10, 20 years ago, to a bit more like the tick box regulation, that had quite some perverse effects where healthcare providers would just work on ticking the right boxes and not necessarily on working from an intrinsic motivation on improving quality. So just to give a bit of an example, the change that the Dutch healthcare sector has made, at least in hospital care in the last couple of years, is that instead of focusing on quality indicators, we've seen that the focus has been much more on what we say learning and also a culture of learning in that regulation. And how that specifically looks like is that the Dutch hospitals don't only need to provide long list of data, long lists of quality indicators, but also have to provide, or instead have to provide improvement goals. So to give you an example, for example, instead of providing all sorts of data on how they score on malnutrition indicators, instead they are asked to explain how they screen for and treat for malnutrition and how they intend to improve that. And so there's a lot of conversation between the regulator and the healthcare provider as well on how that's being done. This is just one example. And again, we can criticize, and maybe this is something for the discussion. I have a lot of questions and criticism on this approach as well, but you see a shift in focus on just accounting for data towards a bit more that learning and improvement, what the regulator is focusing on. Now, and I think, and I'm not going to say too much about this, but I think closely related to regulation is accreditation as well. And you see the two big ones in the Netherlands when it comes to hospital care, I think are quite familiar to at least the JCI must be on an international level familiar. And next to that, we've got Qualicore Europe, who's doing a lot of accreditation, who use the standards of the Health Standards Organization in Canada. And you see a bit of a change there as well in how this accreditation process goes. And one example is, for example, the increased use of appreciative inquiry, and also focusing way more on a culture of learning and how do hospitals improve and learn instead of only accounting for data and indicators. Now, a second thing that I want to focus on is the organizational level and organizational policies. Because what we see happening, we do a lot of what we call action research in hospitals, where we embed ourselves in hospitals and walk along with healthcare professionals and study how they work on quality and quality improvement. And what we see is that existing policies might hinder resilient practices, and that is both in terms of practicalities and in terms of consequences on professionals' behavior. So what I mean with practicalities, for example, is that we know when it comes to quality improvement, it's sometimes important to have multidisciplinary reflections. So with the nurses, with the midwives, with the doctors. It doesn't help then if all your shifts end at different times, and every time you want to have a multidisciplinary talk, the nurse will have to do that in her own time because, oh, well, we do it at 5 because that's, or at 6 because that's when the doctor is done. You just wait 2 hours for that, right? Like you can imagine, that is not very motivating. It also, in terms of consequences on professional behavior, we see that how teams and healthcare professionals have to account for what they do to higher, say, layers in the organization, so in management, impacts on what they do. So if there's a strict policy on and strict governance on data and on that all the indicators need to be on green, need to be correct, that's what healthcare professionals will focus on, and not so much on that learning and reflection on what is being done. And so we've been working with hospitals on how can you create that room for resilience, and working with them on different things. For example, on time, how can you give healthcare professionals, say, a bit of time to work on quality and quality improvement next to that primary bed care, so to say, treatment of patients? How can you change what professionals need to account for, but also the conversations that you might have about the data with management, and work on way more of, say, reflexive practices and reflexive discussions with management on why certain indicators might be negative and what can be done about that, instead of only being told that you have to improve them no matter what. And a third thing that we've been working on is facilitating reflexive spaces of teams. So, for example, how can you include reflection on quality and quality improvement in, say, the daily closures, the ward rounds, and other structures on a department level? Now, I realize that I'm already probably nearing the 7 minutes, but the last thing that I wanted to discuss is that what we notice a lot when we do research in hospitals, but also with healthcare professionals, is that it matters how healthcare professionals and quality officers and managers are educated when it comes to quality and quality improvement, because it impacts in how we try to improve and organize healthcare. And so what we see a lot, and I know that there's quite some healthcare professionals here today as well, is that a standard response of healthcare professionals is when something needs to be improved is we're going to measure something, we're going to obtain data, we're going to collect data, and we might fix it with a new rule or a new guideline. And sometimes that might be really appropriate, but sometimes that is also counterproductive. So we've been seeing a lot in practice that rules that didn't help patient care were actually invented by the healthcare professionals on that department. And so when you reflect on those rules and the data that you collect, that might help create a bit of room for resilience as well. But I think we need to have a bit of a shift in how we educate then about quality improvement. So last thing, because we were asked to talk about how do we write this into policy, and of course that's one thing, but in the end, and this is a bit the research that we do, it's also about then how do people act upon these policies. So that's hopefully within the time and maybe just a bit over, but I'm going to hand over to Cole and then take questions after.
Hello everyone, nice to see you. So first of all, my role at Te Tahu Hauora, the Health Quality Safety Commission, is as clinical lead for system safety. And as part of that, it's an organisation it's not part of the health system, it's not part of the major hospital and specialist system, it's not part of primary care, it's not part of the government, it's an independent commission that is charged with improving the quality and safety of care in the New Zealand healthcare system. So first declaration is that my discussion is really not representing the official views of Te Tahu Hauora, the Health Quality Safety Commission. I'm going to talk a little bit slightly different tack. So in the work we've been doing in the commission, we've been trying to think about, well, how do we build these principles into actionable policy to sort of shape the healthcare system? So one of the things is for me is that, is that I'm quite a pragmatic person. I'm a clinician, and I'm kind of interested in how you affect change. And so I don't come from a research background, so it's kind of theory informed rather than research informed. But just to sort of say that what we start off with, we start with some sort of fundamental kind of understandings about what do we mean by resilient healthcare. So some of the taken for granted things that we build into it. So first of all, healthcare is a complex adaptive system. The adaptive capacity is required to deal with system surprise and change over time at all levels. That understanding the realities of everyday care from different perspectives is a really big part of understanding that system performance, and seeing resilience as this multi-level, multi-scale, as in over multiple timescales phenomenon. And so when I think of resilient healthcare and what we've tried to do, it's really about a lens that we examine policy in all forms. So it's basically, and I'm going to talk about the national kind of level stuff we've been trying to do. So the first thing was really, how do you build in New Zealand, we're kind of particular about words, and I'll talk about that in a moment, but we've had a move away from patient safety to this idea of system safety. And part of the reason for that is because it's about shaping what we mean by the safe performance of a system. It's not just about the experience of patients or are they harmed, this thing that happens. It's about the experience of the workers, the experience of the system as a whole, about how it's changing over time. So one of the first questions is really then, when we talk about regulation or policy, what does it mean to be in control of a system that is dynamic, organic, changing over time? So when you have a multi-level system like a national health system, what does it mean to be in control or to try and influence that? And once you understand that, then how do you amplify control? How do you, if you believe it's this organic, evolving, dynamic, uncertain system, you can't really write a rule for everything. You can't do these top-down sort of procedural approaches. They just don't work. Essentially, they become outdated and become increasingly brittle. So I guess the question for us was, what does governance, or what does policy to support governance look like in a complex multi-agent system? And a lot of my thinking has come from this article by Woods and some of the other work by Woods and Hono. So first of all, one of the really important bits is when you're thinking about policy is that very often people get tied up with, they put in a sentence that says learning from what goes well, or we will bring a safety to perspective, or they put in something like this. We think you have to start off with a real change in what the idea of changing the symbolic meaning. So when we talk about safety, what do we mean? When we talk about, the definition of safety, those sort of things, you actually have to start having conversations with people to talk about how you change that meaning. So, language is, we're creating conditions to support good care as opposed to prevent people making errors. The framing is about, how does the system as a whole shape the conditions of care? Perspectives are, how are we grounded in the realities of care from different perspectives? And then thinking about which models work best, is it a mechanistic sort of procedural model or an ecological model? How are we going to think about interactions across the system as transactional, relational? So there's quite a lot of work in there about the way you use language in policy to shape people's understanding and the way that they're thinking about problems when they come to this. The second thing is that if you write a sort of safety 2 policy out here, then it's not really going to work. It's kind of our understanding. So you have to think about policy not as a particular policy, but as a program of shaping the healthcare system. So thinking about the coherence and compatibility between different policies and how they add to each other to give an overall shift in what you're trying to do. So having an overarching idea of the state that you want to move to. And really for us, this was a thinking about, well, if you're going to take that definition of resilient healthcare, how are you going to build a system that has that capacity to adapt to challenge and change, but at multiple levels? And so that was really part of our thinking about how do you do that in a programmatic way. So some of that really is thinking about, well, how do we change what we pay attention to? So, for example, in our national adverse events policy, we create the focus of what people are paying attention to. both the cases they select, how they look at them, and then the way that they're framing their reports and recommendations. So within this, we've built in restorative practice, but we've also built in patient engagement and family stories. But we've also built in resilient healthcare kind of lenses. And you can see that in some of the language in the introduction here, talking about emergent outcomes, the realities of everyday work, how do we normally navigate risks, the wider system factors. So the whole framing is really thinking about at every level is how you're putting these concepts in there. And you'll notice that we don't talk about safety too. We don't talk about what goes well. We don't put in that kind of jargon. We frame it as this is a way of shaping the way that people think about what you're trying to do in this policy. We change the models, so the tools that we use, and we're thinking about, if you say it's about a system perspective and then your tool focuses on those proximal to an event, it's not going to work. So thinking about changing our tools, so we've taken on board Ivan Popilides' learning review methodology, so thinking about how do we make sense of normal conditions, and then how do we engage staff in the sense making and finding solutions. So basically, how do we call on their resources of how they normally navigate things, what with changing conditions. So thinking about the way tools change what we see within our reports, and therefore change the kinds of information that get reported centrally to the Health Quality and Safety Commission. So once you think about what you pay attention to, then you shape how you pay attention to it. And then you think about the way that information can flow through a system and be aggregated or be involved in making visible underpinning system drivers that are making conditions of work harder or more difficult. And so you'll see this is our clinical governance framework, which is still in draft. But we talk here about, again, the realities of everyday care, how people navigate risk, relationships, interactions, seeing people as the key resource. So at all levels, you'll see the language of resilient healthcare, of adaptive need, the focus on realities is built into the way that we're writing and the way that that is enacted. When we think about the governance, then we're really thinking, so we've now got the information, how we shape it, how it flows, and then what do you do with it? And that's what we have seen as a big problem with structural secrecy, where the kinds of data coming through governance systems are very focused on individual cases, are very hard to aggregate, and it's very hard to see what's happening. And if you think about an adaptive, resilient system, it's really about how do you understand where you are in that space of performance, and how do you use that understanding to inform your decisions about how you're going to create the conditions in the future to deal with the risks you see coming, or to see with, policy decisions, how they're going to work. And so part of this is now getting involved in the policy space of clinical governance about, and we were having discussions today with the ministry and with data people about, what is the data telling us, not about are we compliant with the data or what's going on, but how do we triangulate the data coming through to make sense of where are we, what do we see coming, how are we balancing our trade-offs, do we have adaptive capacity being impacted by COVID or by faster, better, cheaper pressures that we're seeing at the moment, or by organizational restructuring? How are our margins for maneuver changing? And so we're starting to think about how do you not only write policy for this, but how do you operationalize it in terms of the kinds of conversations that we have. The last piece of policy work we're doing is a national system safety strategy. So this is to go along with the WHO patient safety strategy. But this is really thinking about how do we frame things, how do we write policy that supports this idea of a health ecosystem, and thinking about what relationships or capacities are required to create a system that's basically learning and adapting over time. And this is involved bringing together regulators, workforce, people, medication device oversight, disciplinary organizations, and central government, to try and get them to have some sort of cohesive or at least compatible understandings of what are we talking about with safety and what are our roles within that. And I think that's been a big part of trying to write some of the policy as well, is thinking about how do you shape and find these connections between different parts of the system. Just to give some people some feedback, it's not all bliss. There are definite tensions within this. So health regulators they have a model of safety, which is essentially a bad apples model, very procedural focused, quite outcomes focused. They do address some systems issues, but are very focused on proceduralization. The competency part of that is, again, they're very big on assurance, but the role of expertise is kind of we're having discussions with that. There's a political push at the moment to just ask the question of, are we safe? Tell us we're safe, assure us that we are safe, and talking to them from a resilience lens about how hard that is. There's the issues of the public needing their justice and procedural needs met. And then we're still seeing this big push for these kind of industrial approaches. So I think a part of our job is to think about what policies, not only what policies we write that help move resilient healthcare ideas into the system, but also what are the countering influences or countering policies that stop those things flourishing. And so when you are looking at policies within your systems that you see as creating tensions or goal conflicts with staff or goal conflicts with organizations, think about where those policies have come from. What do they represent? What is their underlying model? And what we're seeing is that very often some of our models about regulation or complaints are based on very 1990s kind of models of how safety was created at that time. And so we're seeing this tension develop between those individualistic policies versus what we're trying to do, which are the systemic policies. And so we are now having to work with those agencies to try and understand what would a resilient healthcare lens on, a code of patient rights look like? What would it look like from a disciplinary point of view? And so thinking about, over time with our policies is they also have to be adaptive and changing over time based on the way that they're impacting intentionally or unintentionally on the system. Advice for the journey from our practical kind of stuff. Take time to understand the background safety science. There is a rich history in resilience engineering and safety science. The concepts are there's lots of great concepts in there from Eric and David Woods and lots of other safety people, and then coming up to the modern work we have from all the groups involved in this network. But take time to understand those deeper concepts. Be very wary of jargon and bad rhetoric. Managers can sniff out bad rhetoric. If you say, we're going to create a whole new program of understanding what goes well, it will probably not work for very long in the way you expect. So you have to be very careful about what is the value people have in it, what is the driver, how are you persuading them that this is something they should support over time. And my concern sometimes is with the jargon is that it becomes faddish. And you'll see that at the moment we're seeing a lot of safety 2 stuff being thrown out there without an understanding about what are we actually talking about here. So I think be very careful about jargon and think much more about framing and language. Invest in the relationships, get to know your ecosystem well. So get to know who is doing the measurement, who are setting the standards, get involved in all those pieces of work so you have a voice at the table and can shape those things. And as part of that, I think, is not just going out there and proselytizing about, resilient healthcare, but understanding the needs and viewpoints that they have and how you sort of say, well, what does your world look like through this lens? How would the policy change if we took that viewpoint? And that's my 7 and a bit minutes. Sorry.
That was brilliant, Carl. Thank you so much. Such a good underpinning of the things that ground your approach to embedding these sorts of things in policy. Thank you.